Hello, thank you for having me. My name is Rinki Agarwal. I will be talking to you about hereditary cancer risk assessment. Our objectives today is to provide an overview of hereditary cancer syndromes, to review the obtaining of a family history, and to illustrate the importance of obtaining this history, to review different risk assessment strategies for to identify patients at risk of heritable cancer syndromes based on current guidelines, to review the genetic testing, consultation with a genetic counseling professional, and the meaning and implications of genetic test results. And then from there, a review of management strategies, including referral to the genetics professionals as well as other specialists, as indicated based on the assessment of risk for the patient. For reviewing genetics, we would need to review some basics. This is going back to medical school information that we are all familiar with, but a review is well placed in most discussions. Genes are present on either autosomes or sex chromosomes, and if passed down on an autosomal chromosome and one copy being affected is enough, as seen on that left-hand diagram, that would be an autosomal dominant, versus it requires two carrier parents and then for them both to pass down the carrier gene to the progeny, to the child, and then both copies in that individual are affected, would lead to an autosomal recessive condition. Most cancer syndromes are inherited in a dominant manner, but there are some recessive conditions as well. Penetrance is the other factor to recognize, which is that there is a age-based penetrance of most cancer conditions in patients who are carriers and at risk of having cancer syndromes. And that can be complete penetrance, for example, FAP, where there is a 100% likelihood of developing colon cancer, versus incomplete penetrance, and that would be that you can be a carrier for a mutation, and then there is a reduced or incomplete penetrance. So there'll be people who are not affected by the condition, even though they carry the gene, such as, for example, ovary cancer, the situation of BRCA1 and 2. Expressivity is that the same cancer gene or risk gene can basically cause different kinds of cancers. A classic example of that is Lynch syndrome, which has multiple different cancers that the individual would be at risk for, but some people will develop colon cancer and other people in the family will develop endometrial cancer and so forth. There's also a difference in the age of onset for conditions, for the cancer condition within families, with presumably the same gene being the cause for developing the cancer or the risk for developing the cancer. There is the possibility of having what we think of as germline mutations to be new. That would be where the mutation occurs either in the egg or the sperm of the parent. The parent is unaffected, and then that egg or sperm, when fertilized, is now present in the child who's a de novo mutation, and now that person is capable of passing it down through their progeny. So that, an example of that would be Lee-Fraumeni syndrome. And the other little caveat to sort of recognize is that patients can have a autosomal dominant condition. Again, Lynch syndrome would be an example of that. But if they had both alleles, biallelic mutations of that gene, then they can have a marked increase in the risk of cancer, such as in the constitutional mismatch repair deficiency. In this example on the right-hand side, showing two MSH6 mutations leading to Lynch syndrome in the parents, and then the child has a quarter chance of having biallelic carrier status with increased risk of childhood and adult cancers. So the way these will develop cancer is that you have all cancers starting as a genetic change, and these are generally somatic with both copies being affected. But what if you went through with a family where one of the copies is already affected, and then it only takes the second hit or the second copy to become affected as well? So now the person is homozygous for a deficient gene with its function, in a tumor suppressor setting, and that leads to over time development of cancer. So you're basically a step closer to the development of cancer in patients who have an autosomal dominant mutation in a tumor suppressor gene. So in summary, most cancer syndromes are dominant. They have variable expressivity and penetrance based on the type of mutation we're talking about. And they have this two-hit hypothesis where they're a step closer to developing a cancer. Reviewing a few of the common syndromes, most germline mutations have an increase in the risk of various types of cancers, and there are different organs at risk, and recognizing that pattern allows you to identify patients at risk. And once you identify the risk, you can say that you identified it because of one cancer in the person or in the family, and it allows you to define the additional risks that the person may have or their family might share. So you have a person here who is coming into your office for testing or for genetic counseling and testing, and then as you draw a pedigree, you realize that on the paternal side, you have an aunt with ovary cancer and a cousin with breast cancer who is a BRCA1 mutation carrier. And your patient has a chance of sharing that mutation about 25% of the time, or 12.5% of the time. No, 25% of the time in this situation. And so obtaining a paternal family history in a syndrome that is primarily for women's cancers, so that you're not misled by the type of cancer or organ involved, becomes important. In the BRCA1 and 2, in the Northern European ancestry, BRCA1 mutation are common, 1 in 300, or modestly common, and BRCA2 is still a relatively rare mutation with 1 in 800 people being carriers. There are certain differences in the types of cancers seen with the BRCA1 mutation carriers, seen triple-negative breast cancers, and the BRCA2 mutations having triple hormone receptor positive breast cancers. There are ethnic variations with counter mutations seen in the Ashkenazi Jewish or French Canadian, Icelandic populations, where there is recurrent or repetitive mutations starting from a founder effect at some point in previous generations. BRCA2 is notable for also presence of male breast cancer, and they have an increased risk of prostate, pancreatic cancer, and a somewhat increased risk of melanomas as well. The next thing to discuss would be Lynch syndrome, where you have a person coming in, and the family history would have a preponderance of colon polyps, colon cancer, especially early onset colon cancer, and possibility of having endometrial cancer. But when you are doing that assessment, it's also important to look at your patient, and they came to you with an established Lynch syndrome diagnosis. And if you obtain the family history on the other side, you would see a significant family history potentially on that side, and doing an assessment of that so that you can offer counseling, offer testing, identify risk becomes important as well, as seen on the maternal side of this individual. Lynch syndrome has multiple genes that would confer risk, and they have differences in the likelihood of occurrence of cancer based on the gene that's involved. We've talked about the recessive condition where you can get a marked increase in childhood cancers and cancers in general. The testing recommendations are currently based on Bethesda and Amsterdam guidelines, but you get colon cancer is the predominant risk and the highest lifetime risk. Endometrial cancer, especially in females in the family, would be the other significant risk, as well as some increase in the risk of ovarian cancer. And then there is upper intestinal tract cancers, gastric and small bowel, and then urothelial cancers, so renal pelvis, bladder, skin tumors, sebaceous neoplasms, and then pancreatic cancer can be noted as well. HDGC, or hereditary diffuse gastric cancer, is noted to have a CDH1 mutation in about 25 to 50% of patients who suffer from hereditary diffuse gastric cancer. If a CDH1 gene mutation is identified, you can have other cancers seen in those patients as well, such as lobular breast cancer or potentially signaling colorectal cancers. And so looking at the actual pathology report, looking at what exact cancer was seen and identified in the patient or the patient's family can give you clues to the things that you might find when you do extend testing to that individual. Li-Fraumeni syndrome, a constellation of tumors where you really see a marked increase in the family of cancers. They can be several different types of cancers, including epithelial and connective tissue cancers. There are certain tumors that are hallmark tumors, like soft tissue sarcomas or adrenocortical tumors. And then also breast cancer seen at less than 30 years of age should make one think about Li-Fraumeni syndrome. This has defined Li-Fraumeni syndrome criteria, classic criteria that is utilized to assess a person for screening. There are certainly areas of centers of excellence that will follow Li-Fraumeni syndrome patients and have enhanced screening modalities utilized for those patients to give them protection. There is a large and a growing list of mutations that can be identified and are now included in the multi-gene panels that multiple companies now have available to them. And they have different degrees of penetrance and expressivity, and some of them are autosomal recessive in nature. Knowing about the presence or occurrence of these patterns so that you're thinking about it is the thing that I would leave people with as the big message to take home. Simple things like not exactly cancers, but multiple uterine fibroids, early onset fibroids, because fibroids are generally seen in patients who are older, closer to 30s and 40s. But you have very young patients with having multiple fibroids, having increased risk of renal cell cancers, and a fumarate hydratase gene mutation giving you HLRCC. If you have rare type of cancers, giving you an example as a small cell carcinoma of the ovary, hypercalcemic type, and an evaluation might show you a SMARC4 gene mutation. CHEK2 is now included in most multi-gene panels, and it gives rise to modest breast and colon cancer risk. There's specific types or locations of mutations where you can define a difference even within the CHEK2 mutations, a difference in the expressivity of it with the cancers and the likelihood of cancer development. CHEK2 is one of the mutations or genes where consideration is being given to polygenic risk scores, which is a topic that really can't be covered in a short talk such as the one we're doing today. And then MUTYH, or as we refer to as MUTYH, is an autosomal recessive condition with colon polyposis and colon cancer. As you find information or recognize pattern, the strategies to use is to ask for your community, look within your community for a genetics professional to look at national guidelines, gene reviews, or do a literature search for assessment and understanding of that disease, so you can disease risk, so you can comfortably talk to people about it. If you have an increase in the risk of cancer, you basically are also able to identify what organs are at risk and what strategies can be used. And this is a continuously evolving field. The recognition of the pattern within a family is going to require collection of a family history. The importance of this cannot be overemphasized. Obtaining a 3-generation family history, especially for cancers, but also for unaffected and for medical conditions, and that these should be analyzed and then be updated regularly as patients return to you for subsequent follow-up, is something that has been now supported by multiple guidelines by different national groups. There is the growth of screening tools. So you have within the electronic medical record or in paper forms checklists that can be developed or have been developed by different groups that will allow you to say, okay, this person is falling within a pattern where genetic testing or counseling can be considered. And as the family histories of patients evolve over time, again, emphasizing the importance of updating that family history regularly. The checklist and your sense of increased risk would fall with if you have multiple cancers, early onset of cancer, rare type of cancers that fall within certain disease paradigms, if they have associated birth defects and certain types of cancers, or they have a heritage where there's known founder effect in the family, would all prompt you to basically consider genetic testing or genetic counseling followed by genetic testing in those patients. So once you say that there may be increased risk and it's appropriate to consider it's appropriate to consider genetic counseling, there are now tools that have been developed for determining that this person should get counseling or testing, and that would typically be to a genetics professional. Referral to a center of expertise with expertise in this is important because the genetic counselor can do the appropriate assessment, do pre-test and post-test counseling, determine the appropriateness of genetic tests. And certainly you may have knowledge of counselors present in your community, and it is very good if you have those services in your community. Genetic counseling is somewhat difficult to identify and is not as widely available as we would like. So there are national resources or websites that will provide you with information on the availability of counselors. And there has been a growth in the use of telegenetics so that you can be somewhat remote from the counselor, and they may still be able to provide services to your patient. There has been a growth of direct-to-provider or direct-to-consumer genetic testing. As far as providers is concerned, there is need to recognize that it requires a fair bit of understanding and expertise in cancer genetics. You have to be able to provide the counseling, the risk assessment, the education, and adequate and competent interpretation of test results. You have to counsel them, and it's required that you counsel them about cost, insurance coverage for it, and then regulatory issues, long-term care, and healthcare insurance issues, and to be familiar with the rules and regulations and federal protection for patients when they go through a genetic risk assessment. When this is not done correctly, there is liability when you don't offer counseling. There's also liability if the counseling is not offered well, such as failure to obtain a family history or appropriate testing, failure to refer the patient to an appropriate genetics professional, misinterpretation of test results leading to an incorrect intervention being done, failure to encourage sharing of results with family members and offering or facilitating cascade testing, and failure to comply with use of appropriate labs and consent forms. In New York State, you have to have a written consent form in order to go through testing. When you make a referral, you're using criteria to establish the referral streams. And then when the patient is seen by a genetic counselor, these are trained professionals that are familiar and have expertise in explaining the medical genetics and family implications for genetic contribution to disease. They are trained in handling assessment for testing, justifying testing, making plans when the patient chooses not to have testing, and if they were to go through and identify risk, counseling the patient on that risk. So they have, these are the basic tenets, the genetic counseling tenets, which is to do an assessment, to educate the patient, to have guidance and walk through different scenarios for when the test is positive or negative, what expectation can the patient have from getting that information, understanding the motivation for going through this process of assessment and testing, and then to help with informed decision-making with regard to testing and possibly for further management beyond. As I said, at least in New York State where I practice, it is required that there should be the informed consent where the patient is given an opportunity to review the information and consent to it, not simply signing a piece of paper, but actually understanding the implications of the process and the test results. Once the counseling is done, the components that are identified is who's the best person to test, what's the most appropriate testing, which lab to use, whether there should be a priority to the genetic testing, and whether any samples need to be stored, what are the reasons for testing, and how what sort of recommendations can come out of anticipated results, and who else in the family would be impacted by the testing, as well as coverage eventually for the testing from insurance and out-of-pocket expenses. One important thing to recognize is when the patient is referred to the genetic counselor, they may look at and do an assessment based on the patient's personal and family history, and determine that they don't actually qualify for genetic testing. They would actually be inappropriate to put them through that process, and so that's a possibility. Once patients go through the counseling and they accept testing, recognizing that this is DNA-based testing, so you are using a diagnostic tool, not a screening test. There are myriad labs, but there are many labs who offer testing, and they have different things in their panels. They have different databases that they refer to, where they're drawing information, the scientific information, to allow you to have interpretation of the results. And the test interpretation is fairly complex. And then once the test result comes back, it needs to be applied to the family history and the patient's specific information to come up with recommendations. The extent of testing can be pretty wide. You have a known mutation, you can do a single-site testing, as you can see in the center of that graphic. You have founder effects in the groups that we've referred to before in this talk, and then you can do basically just founder mutation testing. Single gene, or like a full assessment of a particular gene based on a pattern of disease. You have a pattern of disease, but you're trying to catch everything that could be a possibility using multi-gene panels. And then a little bit less used right now, but the existence of whole exome or genome-based testing. Insurance authorization or possibly even pre-authorization is necessary to run the test. There is a potential as you run through, just like you do with other multiple tests, there is potential to have variants or variants of uncertain significance, which is basically that there's a difference in, there is some change in the genome, and it is not classifiable at this point when compared to ClinVar or other databases into either a benign mutation or a pathogenic mutation. And those then remain in that unclear and can't be further classified until there is sufficient scientific evidence to put them into one group or the other. So the reclassification or classification of variants, it depends on the degree of confidence for the probability of pathogenicity. As your confidence towards pathogenicity improves, you will classify those as being definitely pathogenic with 99% confidence in the pathogenicity of it. Likely pathogenic, where you have a 95 to 99% confidence, and so on. And you have to also, on the other hand, be very confident that this is the polymorphism is just a polymorphism to be a benign variant. And there are, American College of Medical Genetics has issued guidelines for the scientific evidence that would allow you to follow that paradigm of the degree of confidence in order to reclassify the VUS into pathogenic or benign variants. Once the test result comes back, the patient is invited back to have a review of the test results, to discuss the implications, to assess their ability to absorb the information, to process it, to make management plans, and to provide guidance for the patient, and establish recontact, establish referrals, and so forth. So the possibilities are to have a positive test result. You have you looked at a set of genes, and some gene in there identified risk for the patient for cancer. As you do the multi-gene panels, you can have the patient really came in with a history of breast cancer, and you did a multi-gene panel and you didn't have anything in the breast cancer genes, but you really found something that gives them increased risk of, say, colon cancer. And so that's a possibility, and that's one of the risks of multi-gene panels, that you're basically providing them with information that would still be useful, but potentially not something that they really asked for or directly sought for. And that's going to be part of your pre-test counseling. If they're positive, then you are looking at what the gene is to define the cancer risks, and then further management recommendations with options for prevention or early detection and management of it. It's also important to make a plan to identify all patients' family members who would be at risk, and to make some suggestions or recommendations to the patient, because you're not legally allowed to reach out to family members unless you already had a provider relationship, but to identify those patients for cascade testing or at-risk individual identification and then testing to be provided to them using those genetic counseling resources that we had alluded to before. What to do with the positive test results based on what gene it is. There are certainly increased surveillance, prevention, such as chemo prevention, surgical prevention. And then when they do get a cancer, there is now an increasing repertoire of treatment strategies that utilize the genetic testing information to target the cancer when it occurs. The guidelines for management are continuously updated. NCCN publishes guidelines, which are probably the most respected and are updated at least annually and sometimes more frequently. Recognizing that even though we're legally not allowed to reach out to family members, they really are at risk, and doing appropriate counseling for patients so that even before testing, this is the ideal time to go through that counseling. They are prepared to share that test result and recognize and are capable of passing on the benefit of getting this information to family members. We get those variants of uncertain significance, and the big things to communicate with patients is that they need to recontact, and typically testing companies will also recontact them to update them when the VUS is reclassified, but to not act on it at the time of the testing, because it's inadequate data to suggest that it's going to be pathogenic or benign. A greater proportion of these are going to be polymorphisms of benign changes, but to not make any assumptions in that regard. And then using the family history or individualized risk factors, more based on not testing, but family history, to make recommendations for screening as necessary. Okay. If you have a negative test result, but the patient came in and they had a significant family history, it really becomes a question of what is known about the family. So you have your patient is the first person that's coming for testing, or they don't have enough information, or the family has gone through some testing and they don't have any known mutation in the family. Then your negative test result basically says, well, you looked at certain genes, you don't really have a mutation in the genes that you tested for, but you don't have what was causing the cancer in the family, and therefore you really can't absolve the patient's potential risk and vulnerability to cancer. And so you use a risk estimation method for the particular condition based on family history alone, and sometimes can modify it to some degree based on negative testing results, but they may remain at elevated risk. On the other hand, if a patient has a known mutation, I have a sister who has BRCA1 mutation, and I'm here and I have this significant family history, but the history is attributed to the BRCA1 mutation that we know about in the family, and I go through that testing and it's negative, then my risk is very different, and I still have to look at the risk factors that I have otherwise for breast cancer. But it's not coming from that BRCA1 mutation because it's not shared fully, but present in the family. So what's the level of risk, and then the post-test risk can go down dramatically in patients who have a known mutation in the family that they test negative for. There's also patients who will come in and for different reasons, personal, insurance, or otherwise, will decline genetic testing. And our recommendations to them are, again, based on a personalized cancer risk assessment, and that they should be trying to understand why they're refusing the genetic test, trying to make sure that they understand the benefit that it may provide for them, and then respecting their desire as long as they're well counseled, well informed on that decision, and making recommendations still for prevention or screening interventions based on their risk score without including genetic testing becomes important. So in summary, we have a large number of labs that are offering genetic testing that includes multiple genes, with very large numbers of panels now available commercially for testing. These need to be carefully applied with justification for whatever test is ordered. It is important to consider adequate pre- and post-test counseling and to interpret those test results in light of the patient's family history and personalized risk assessment scores, and to be prepared to deal with or address any complex interpretation issues either independently or with the use of a genetics professional, and certainly use a genetics professional to make sure that you're giving the best recommendations to the patient. So with the patient at the center of a paradigm, there's really the family history kind of sets you off on a path of defining risk and defining management strategies. But at that point, it becomes, to me, a multi-person professional approach to taking care of that patient, with the patient at the center, within the PCP, a genetics professional, and other oncology or other health professionals that are adept at managing the risk for the patient once it's been defined, become important in the process. Several institutions now have groups of individuals who are capable, and they do all of the education, self-education, to keep abreast of knowledge of genetics-related risk, so that they can counsel and manage those patients, breast surgeons, surgical oncologists, GI specialists, gynecologic oncologists, and having this collaborative network so that when your patient comes back with enhanced risk, you are able to utilize this network for management of the patient. The patient is an important collaborator in this, and one of the things that I have experienced with as we deliver information to the patient and you identify multiple risks for the patient, sometimes you have to ensure that the patient's getting the information, but they're getting it at a pace that they can actually deal with it as well. And then that's a discussion that happens over not a single visit, but or a couple of visits, but in a more ongoing fashion, so that they can accept the information and go through all of the things that they need to until they have a good plan for management of their risk. So in conclusion, we as medical professionals have an important role in identifying patients who have a cancer risk. This is typically done by obtaining a relatively comprehensive family history and using tools to identify patients who would benefit from counseling, use of genetics professionals or trained clinicians who can provide counseling, identify and define risk, as well as navigate genetic testing with patients, and an understanding of testing options, which are now increasingly complex and require constant updating of our knowledge and utilization of that genetics professional to navigate this information with the patient becomes important. Having a network of providers who have the knowledge and expertise to assist your patient in risk management and keeping abreast of the growing knowledge, the amazingly growing knowledge with the resources available to you now in our networked world, and using your local and national resources to facilitate best care for the patient. With that in mind, I'd like to thank you for your time, and my understanding is that there will be an opportunity to ask questions, which would then be emailed to me, and I'd be happy to take any questions and provide assistance. Certainly in New York State, we are at Upstate Cancer Center, and I have a fairly robust telegenetics program with the counselors that work with me, and we would be able to provide services to anybody who falls within New York State where we're licensed to practice. And I would invite you to use us as we can be of assistance. And I appreciate your attention. Thank you.